All right, welcome to the basics of Cath Lab orientation. Stay tuned for a bunch more fun stuff to learn. We're going to talk about all of the equipment that we use and kind of where to find it. So it's important to know where to look for these items and kind of what you are going to use with them. In your orientation binder, you are going to have a scavenger hunt, and you can use that, go with your preceptor to find all of these items so that you know where they're at and can kind of go through what they're used for and what else you will need with them. Now to go into the basics of coronary anatomy. So as you're coming into the cath lab, this is a lot of new information for a lot of you. And so we're going to kind of go through the basics. So a normal coronary anatomy, there is a normal epithelial layer that maintains vascular health. It produces vasodilator substances, hyperpolarizing factors, vasoconstrictor substances, tissue factors, structural components of the extracellular matrix, and growth factors. There are anticoagulant and antithrombotic surface preventing platelet aggregation, and there's a barrier from the blood in the vessel to the arterial wall. Your tunica media is your smooth muscle that controls the lumen diameter with contraction and relaxation. So that response is blunted in diseased arteries. So it doesn't contract or dilate as easily when you have a lot of plaque in there. And your adventitia is a small network of small vessels feeding the main vessel. So this controls the vessel tone using nerves and pressure receptors. Your coronary circulation includes epicardial vessels. So that's your main coronary arteries are epicardial, so they're on the outside of the heart muscle. So you have your left main coronary artery, which branches off into your LAD, your left anterior descending, and your left circumflex. And some people do have a third branch, which is called the ramus intermedius. On the other side, you have your right coronary artery, and they all originate from the aortic root, located at the right and left sinuses of Valsalva, a centimeter approximately above the aortic cusp. Coronary dominance, you may hear this throughout different cases that you're in, that the docs will mention that they are left-sided dominant or right-sided dominant. And the way that we identify this is where the PDA, the posterior descending artery, originates from. Most people have it originating off of the right coronary artery, but some people do have it coming off of the circumflex. And you can see the right coronary artery and the circumflex kind of both go around to the back of the heart. And that PDA, that posterior descending artery, is almost the mirror image of your LAD. So as your LAD is your left anterior descending, your posterior descending is kind of covers that bottom of the heart. So your coronary anatomy, you have your left anterior descending, which is your anterior in the intraventricular groove, so it goes right in between your right and left ventricle. It starts above the pulmonary artery and travels down to the apex of the heart. It has diagonal branches, which supply anterior free wall, and then there's the septal perforating branches, which go into that septum. Your left circumflex goes into your left AV groove, so right in between the atrium and ventricle on the left side. It goes posteriorly under that left atrial appendage and supplies the mitral valve. It is the reciprocal of the right coronary artery, as I mentioned before, and has obtuse marginals, or OM branches, that will branch off of the left circumflex that are similar to the LAD, which has diagonal branches. Your right coronary artery sits in that right AV groove. So think about the circumflex sits in the left AV. Your right coronary artery fits in the right AV groove. It feeds your tricuspid valve, and there are occasionally a conus branch, which is this first branch that feeds off of the right ventricular outflow tract. That is a branch that we occasionally will cannulate, and oftentimes if we cannulate that conus branch, watch for VFib, speaking from experience. And then you also have branches, your mid-RCA will flow to the right ventricular free wall in the atria, and your PDA often coming off of the right. Again, we talked about how it can come off of the circumflex as well, but most of the time, in most people, it comes off of the right coronary artery. It feeds that posterior medial papillary muscle, and it's more vulnerable to mitral regurgitation. Your venous anatomy is your coronary sinus. You'll hear a lot more about this vein in EP, but it brings blood from the coronaries back to the right atrium. It sits in the AV groove of the posterior wall. And then there is the right cardiac venous system, which has an anterior lateral surface of the right ventricle. So some coronary anatomy collaterals. So these are embryonic development of small arterial channels connecting coronary arteries. They're small, thin-walled channels, and they increase in diameter and develop in muscular media to transport large amounts of blood. They enlarge in response to coronary narrowing, myocardial ischemia, hypoxia, or anemia. These are not branches that are regularly visible or seen in normal anatomy. We often see these in CTOs, so the chronic total occlusion cases. When we see these, this is your body's way of accommodating this long-term blockage. All right, and then back to coronary artery disease. So cholesterol-containing deposits or plaque and inflammation occur in the arteries of the heart, creating reduced flow and ischemia. Cholesterol is going to cause this, and then the symptoms you're going to see are some angina and shortness of breath, which are common symptoms of coronary artery disease when a blockage becomes occlusive to the vessels, leading to a heart attack. Causes can be smoking, hypertension, high cholesterol, diabetes, and a sedentary lifestyle. Some risk factors for coronary artery disease: older age, men have a higher risk, family history of CAD, hypertension, high cholesterol, diabetes, obesity, physical inactivity, an unhealthy diet, high in saturated fats, trans fats, salt, and sugar. And usually multiple risk factors are present. Usually it's not just one of these risk factors causing some coronary artery disease. Usually it's a combination. Other risk factors are sleep apnea, or sudden pauses in breathing can even cause strain on that cardiovascular system. High sensitivity to C-reactive protein occurs with inflammation. High triglycerides, homocysteine levels are high, preeclampsia, alcohol use, and autoimmune diseases. So atherosclerotic plaque. So they contain inflammatory cells, macrophages, lymphocytes, neutrophils, mast cells, and platelets. They contain an extracellular matrix. They contain lipids in the lipid layer debris and within the intimal layer of the vessel. So you can see here we've got a normal flow anatomy and then some endothelial disruption where that fatty streak starts to form. And it kind of gets bigger and bigger where you get some fibrous plaque and eventually causing a plaque rupture or thrombosis. And that's where we get our acute MIs. So how does this happen? So we've got healthy endothelial cells in the vessels. They regulate vascular tone and permeability. They control that inflammation and thrombosis and produce nitric oxide, which promotes vasodilation and prevents platelet adhesion. Those unhealthy cells have that reduced production of nitrous oxide, and they increase platelet aggregation. So those fatty streaks form areas with higher platelet aggregation, and in turn, it causes some vasoconstriction. Plaque erosion or rupture causes unhealthy cells, areas more open to platelet adhesions. Continued inflammation leads to more lesions and more platelet aggregation, leading to eventual disruption in acute coronary syndrome. So you can see the stages of development here. We've got their fatty streak development leading to that plaque progression and plaque disruption. So pharmacological treatment for these. Oftentimes you're going to see all of our patients on aspirin. A lot of them will be on statins as well. We'll make sure that we look at this in our pre-procedure meds or home meds before our case gets started. We want to make sure that they are on aspirin, and we want to know if they're on a statin or any post-PCI antiplatelet medications. So aspirin is an antiplatelet, and so it prevents platelet adhesion by blocking arachidonic acid. This is kind of the first line of defense. Even patients who are coming in who are not usually on aspirin, they get aspirin the morning they come to us. Statin therapies will decrease inflammation, and they block cholesterol production in the liver. And the post-PCI antiplatelet therapies are Plavix, Effient, and Brilinta. And so you can kind of see over here the forming of a blood clot. You've got your platelets. They're a type of blood cell that stick together when activated and stick together to form a plug. And so those antiplatelet drugs work by making those platelets less sticky. You've got your blood clotting proteins and your anticoagulants. All right, so then let's get into rhythm interpretation. And so this is kind of a basic where you're looking at on an EKG to kind of identify where there is some concern and what vessels we would want to be thinking about looking at. So we've got our leads 1, 2, and 3, and then our AVR, AVL, AVF, and then our V1 through V6 leads. So you can see there where we're close to. So for our procedures, we've got our patient setup. We're going to talk about left heart caths, percutaneous coronary intervention, right heart caths, and peripheral caths. So our patient setup. So when we get the patient pulled into the room, we're going to pull them up in merge and x-ray. We want our 5 lead placement, and you can see in the picture here where those leads are going to be at. We use our oxygen tubing with capnography. We are not using that at this time, but potentially in the future we will be. You put your blood pressure on, your pulse ox, and your groin or your wrist needs to be shaved. The ChloraPrep takes 3 minutes to dry, and it'll be draped by your person who's scrubbing in. When we are ChloraPrepping and shaving these areas, we want to have a large enough area that we have enough room to work with. So especially the groin, we do about belly button to knees, and medially enough that we can get access, and you're going to want to go more medially than you think on patients who are a little bit larger, because just because their adipose tissue is further out laterally does not mean that their arteries are further out as well. So make sure that we are prepping very medially as well. So left heart cath. So what do we do these for? We perform them to determine the severity of coronary artery disease through angiography under fluoroscopy. This is a low-risk procedure, and the most common complication is bruising at the access site and sometimes some nausea. We are able to identify blockages in the coronary arteries, which can be angioplastied, stented, or sent for a surgical consult, depending on the severity. It can be completely through the femoral artery or the radial artery. Conscious sedation is used at the discretion of the physician, and anticoagulants may be used, such as aspirin, heparin, or Angiomax. Most of our docs at this point are using heparin. Aspirin is typically given in holding or at home, and Angiomax is an option as an antiplatelet, but it is used less frequently than we used to use it. So our access sites are femoral and radial. So our femoral access, we can use larger sizes if we need to. So if we need to go up to an 8 French sheath or even larger for some of our devices, femoral is the ideal location. Shorter catheters can be used as well. It's actually a shorter distance from your groin all the way up to your heart than your radial artery all the way down by your wrist. And it's a lot less tortuous to go from the groin. It's a very predictable location. You can kind of gauge off of where your femoral head is. You've got palpable and x-ray markers that you can identify and assume where your artery is going to be at. We also have been using ultrasound a lot lately as well, which improves our likelihood of success with accessing the artery. That femoral head offers support for manual compression after the case. There is a high risk for groin complications, obviously because radial cases are not using the groin, so they wouldn't have any groin complications. We aim for below the inguinal ligament, but above that bifurcation of the SFA and profunda. And we can see there we've got our our access point here. And so we've got our inguinal ligament up here, and then down here is where we've got our bifurcation of our SFA and profunda. So if we go below that bifurcation, that's a much smaller artery than the common femoral, and so that's why we don't want to go too low. Our considerations are our patient size, the ability to lie flat for potentially 4 hours, their pulse, and their previous vascular issues. And typically we have a lot more push for radial access over femoral at this time. And so we'll go on to radial. So there's pretty straightforward access and hemostasis with that superficial artery. You can feel most people's pulses without any issue. It's increased patient comfort after the procedure because they can sit up, they can move around a little bit more. They just kind of have to act like that wrist is broken. It obviously lowers the vascular complication and hospital costs. It's a smaller caliber vessel, and we use an antispasm cocktail during the case composed of nitro and verapamil, and that's administered right through the sheath into that radial artery. Heparin is also administered, whereas for the femoral cases, we don't necessarily administer heparin unless we are doing a PCI. But some considerations are your pulse strengths, your ulnar artery patency, and then Allen's and Barbeau. And so we want to make sure that we're testing to make sure that there is enough blood flow to the hand. And if there's not, then femoral access may be indicated. And when we are prepping for a radial case, we do prep the wrist and the groin because we always want to have that backup plan. So for a left heart cath, we use local anesthetic given at the needle entry site. The vessel wall is punctured at 45 to 60 degree angle to prevent perforation of that back wall of the artery. Ultrasound guided access can be used for difficult arterial entry and is becoming more of the standard of care. The wire is placed through that needle and the needle is exchanged out for a sheath. Catheters are advanced over the wire to the aorta, where the physician manipulates it to cannulate those coronary arteries. A high stick is above that inguinal ligament and may result in laceration of the epigastric artery or inability to obtain hemostasis with no support of compression with the femoral head, and can also cause a retroperitoneal bleed, which is required for surgery to participate in that one. A low stick is considered below the bifurcation of the SFA and profunda. Some issues with that are bleeding around the sheath, limb ischemia, a pseudoaneurysm, AV fistula formation, and retroperitoneal bleed. So we use contrast dye. It's injected through the catheter to visualize those coronary arteries. Blockages can be identified and treated with medications, percutaneous coronary intervention, or surgery. So we can see there's that tight spot in that right coronary artery in the mid to distal section. So depending on what the left side looked like, we could treat that one pretty easily with a stent. And then there's also these additional pictures. This is the left coronary system. We can see some blockages. On the left picture is of the circumflex, and on the right picture is of the LAD. And so then our right heart cath. This is a procedure where we measure the pressures of the right side of the heart. So we're measuring the pressures of the right atrium, right ventricle, pulmonary artery, and pulmonary capillary wedge pressure, which is an indirect measurement of the left atrium. We take oxygen saturations at a minimum PA and arterial, and this will give us our cardiac output from a FIC level. It is venous access. We can go femoral, IJ, and then as well as brachial. The indications are heart failure, valve disease, shock, congenital heart disease, pulmonary hypertension, cardiomyopathy, or a heart transplant. And so you can see the location of the wedge catheter in the image to the right, as well as the pressures to kind of expect what you're looking for. And you'll notice that the pressures that you see in the heart on the right side are comparable to the left side. So you see your right atrial pressure and your wedge pressure look pretty similar. And because that is an indirect measurement of the left atrium. So the atrium have similar pressure waveforms. And you'll notice as you're going through cases that your RV waveform looks very similar to your LV waveform, as those are both ventricles, and your pulmonary artery as well as your aorta. So we want to maintain our baseline oxygen status during a right heart cath. So if they're on oxygen at home, they can be on oxygen. And if they are not on oxygen at home, we want to turn that off. Less sedation is used for these procedures, as sedation can change the results a little bit, where we're not getting totally accurate measurements of what their baseline non-sedated pressures are. Biopsies can accompany these procedures, especially with pre and post heart transplant patients. And the FIC cardiac output requires an AO and PA saturation. Our heart rate must be documented as well. And so here's a little measurement of those pressures and kind of comparison again of what they look like from right side to left side, that those waveforms look similar, just on a very different scale. All right, just a little bit about radiation safety. Our best friends in keeping ourselves safe are time, distance, and shielding. So minimize that time you expose yourself to radiation. Stay at least 6 feet back at all times, and that's why we've got the floors painted those different colors. That widest circle is your 6 feet back, so always try to stay about there as much as you can. And then we wear our lead aprons and eyewear. And that's all I got for you.